afternoon. How's everybody doing? I just want to say thank you for making me lecture during my lunch. Okay, but I'm so selfless. I'm here for you. What we're going to do, just as a joke, what we're going to do the first couple of minutes here is kind of go through some of these lectures that we had to do remote during our apocalypse freeze day. And so we're going to start with acute asthma. Are there any questions about this lecture? No? Okay, give me the 4 main treatments for acute asthma exacerbation. SABA would be good, right? Because asthma is reversible. What else? I'm sorry? Ipratropium or an anticholinergic, really good. Okay, we get a better result from that, especially with our COPD patients, but that's our second choice. That's an adjunct we can use, and if we mix it with the SABA, it's called a duoneb, and that's really advantageous for our patient. What's another medication for acute asthma exacerbation? Steroid, right? It's reversible. Now, will the steroid work right away? How long does it take for a steroid to kick in? Hours, right? So does it matter if I give it orally, intramuscularly, or IV? The bioavailability is the same, but the reason why we do IV medications for very, very sick patients, because if they're so exacerbated in their asthma that they can't actually communicate or talk or phonate because they're struggling to breathe, that patient warrants some sort of IV medication. Do we agree? Right? Our safety net, the emergency department, IVO2 monitor, right? So, okay, then they would get an IV steroid. Otherwise, by and large, most of our asthma exacerbations are mild, right? Reversible, especially if we throw the kitchen sink at them early, and they can get oral steroids. That would be the briefing I just came from. Okay, that's the gentleman that works directly with the CG. So we just had an all-staff briefing from 11 to 12, which is why I just ran up here in between. And I guess they ran right after me. They're like, where's she going? And then they chased me up here. I think that's what happened. They're like, I saw her, she had a water and a peanut butter and jelly. So they came up after me. Okay. So what's the other treatment that we give everybody that seems like they're struggling and in terms of breathing? Oxygen. So our 4 main treatments for somebody with an acute asthma exacerbation is first and foremost, if they're struggling, put them on some oxygen. Get them that SABA, which is albuterol or Ventolin. If we mix it up in a little inhaler or nebulizer treatment, that's really good. We can give it to them really quickly. If we mix it with ipratropium, which is also helpful, we call that a duoneb. 2 meds, hence duo, together in 1 neb. Awesome, right? And then lastly, the corticosteroids. Now, how long, if let's say the patient's reversible asthma condition turns around and they get better, how long do we need to send them home as an outpatient on steroids? Typically 3 to 5 to 7 days. I think the sweet spot is at least 5 days, okay? And the key with asthma is that it's reversible. I think I said this on the presentation, which I know some people haven't even listened to, right? And that's why I recorded it for you, because Canvas and Blue Button only holds the lectures for a week. I knew my exam wasn't for several weeks, so it was going to erase anything we did online. So I recorded those for you so you had them for several weeks. Okay, so that's why. And it's really boring. You know how boring it was for me to sit there on MLK Day and talk to myself? Okay, it wasn't fun for me, and that's the most important thing, okay? Is that it's very boring for me to hear myself. I had this like terrible mundane, and then when I was trying to check myself, I was like, gosh, do I really sound like that? Anyway, so those are the mainstays of acute asthma exacerbation, but what happens if we're having a patient with asthma and they're exacerbating and they're continuing to circle the drain? They're getting worse no matter what we're doing. What's next? What are some backup things that we can pull off the shelf in a crunch that we don't do for our typical asthmatics, only the ones that are really crumping? What do? So Epi's fantastic. I would try magnesium first, so I know you guys want to have a stepwise approach. Okay, it's oxygen, SABA, ipratropium, corticosteroids. We can do a 1-hour continuous neb, which is 3 back-to-back duonebs. We call it 1 hour continuous. Instead of giving 1 every 20 minutes, we put 3 all in 1 big chamber. We just let them breathe it for an hour. Okay, that's a 1 hour continuous. Next step, okay, they're not coming around. We're going to do magnesium, 2 grams IV, slow push. Why slow push for magnesium? there's a theoretical risk of hypotension, right? We don't want that in somebody who's already having respiratory issues, right? So we throw 2 grams of IV magnesium at them first. Does anybody know how that works? Yeah. Yeah, it's a smooth muscle relaxer. They think there's some bronchodilatory properties, but the real answer is we're not really sure. Okay, we're not exactly sure how and why it works, but it does. So we throw magnesium at them. That doesn't work. What's our last ditches? Okay, what's our next step? I heard it, epi. Okay, push dose epi. Epi is fantastic. Generally, we try not to give IV epi to anybody who still has a pulse, right? Usually we do IV epi or IO epi to somebody who's pulseless. But there are some exceptions, and that's for severe asthma exacerbations, which we call status asthmaticus. All right, we'll do a little push dose epi, okay? You can give 10 micrograms or so, and really we draw it up, and I'll teach you guys how to do it if I'm still employed in a few weeks. It's really an awesome bedside tool to have. Also, we do it for septic patients, all right, and even some patients in cardiogenic shock. You can do some push dose epi. All right through the IV, okay? But what if I don't have the time to mix up epi and I'm confused, cardiac epi, anaphylaxis epi, what do? Can I just give them an EpiPen or a little IM injections of epi? You bet. Okay, give them some epi, do something. What if they're still circling the drain? What am I having to do? I'm sorry? So I may have to intubate, right? And intubation for an asthmatic is bad. And why is it bad? Yeah, because all I'm doing is controlling the airway. I'm not even, they're still having the exacerbation. They're still having the hyper-responsiveness. So I'm still going to have to do nebulized treatments through that UT tube, right? The benefit is to secure the airway because now they're so tired, they're altered, and I have to secure their airway for them. And if I have to do that, I'm going to use an agent like ketamine as my sedative because it has bronchodilator activities, which is fantastic. And then I'll probably use a long-acting paralytic like rocuronium, okay? And then we're still doing inline nebulizer treatments through the ET tube and through the ventilator, and then we're still doing IV steroids, okay? Just want to make that clear. Any confusion about asthma or exacerbation? It's reversible. It's supposed to be reversible, right? And I can tell you right now, I've been close where I had to give multiple doses of epi to a patient before who's really bad. But I've never actually had to intubate an asthmatic. And I've worked with doctors that say you should never have to intubate an asthmatic. If you do, it's because you weren't aggressive enough early enough, okay? So don't be afraid, but luckily this is a small subset of our population. Most asthmatics come in, mild exacerbation, you hear some wheezing, you give them a little neb treatment, they're doing better, they feel better, they're not retracting, they go home with a nice asthma action plan. Is that a good summary of asthma? Any questions about it? Sure.
So if you have a patient that comes in and you kind of get that feeling that it's going to be somebody that's going to have a...
What's that feeling called?
Gestalt.
It's called gestalt. I love that word. Okay. That's awesome. All right, you got an A for today already. All right, we're here.
Just like this person's going to just be in a bad way here soon.
Mm-hmm.
This wouldn't be a stepwise approach where you would be a kitchen. You could just go kitchen sink.
Oh. Yeah, the reason why we do stepwise in this environment is because you guys are supposed to read a little artificial vignette and then make stepwise decisions. But in real life, if like you're right, you see somebody, hey, they're retracting, they're tripoding, accessory muscle use, maybe you can't even hear air moving very much, maybe they're a little hypoxic. I'm automatically, hey, 1 hour continuous neb, steroid, the oxygen, the nebulizer can be hooked up instead of room air connection, or to hospital air, it can be hooked up to oxygen, so you're also oxygenating them during their neb. You can do all that at once, and I already pull the airway cart to the bedside, and I'm already getting my push dose epi kind of drawn up, ready to go, and I say, go ahead and start magnesium, 2 grams IV, okay? That's for an adult patient. The dose is a little bit different for peds, but absolutely. And as time goes, and the more you practice, your gestalt's going to get more razor sharp. Okay, you may have some or feelings of imposter syndrome, kind of some way in phase 2, and that's normal because you're like, I'm supposed to be able to handle this by myself, but you haven't really had enough encounters to feel really confident yet, and that takes time. And there are still days, I've been doing this for 25 years, 17 as an emergency medicine PA, and there are still days that I get rattled. I mean, that's legit, okay? Medicine will humble you. So that's right, though. If you see somebody, you think they're circling the drain, be aggressive early, go ahead and draw it up, okay? We don't just slam magnesium and ketamine to just anybody. We're gonna try to do our due diligence and stuff first, but I just wanted to make sure that you knew the gist of the asthma stuff. Here's our 4 main treatments. This is important. I would definitely know this, okay? And know that if you put SABA plus an anticholinergic like ipratropium, that's considered a duodenum, okay? All right, moving on. What was the next lecture that you guys did or did not listen to? I'm sorry? Pneumonia. Okay. Real quick, what's the mainstay of treatment of pneumonia? Thank you. It's a beta-lactam and a macrolide. Everybody gets that except for the very, very sick. And who are they? Who's the very, very sick? People with CAP, hospital-acquired pneumonia, ventilator-associated pneumonia, and anybody that needs to go to the ICU. How do I know if somebody needs to go to the ICU? Who's in, what criteria, and I think I tried to explain this, what's the difference between just like a step-down unit but in the hospital versus an ICU in the hospital? I'm sorry? Yeah, if you're in a step-down unit, and let's say you're admitted, and you're in a step-down unit, your nurse is taking care of 3 to 4 patients, all right? If you're in an ICU, you have your own nurse, it's 1-to-1. So ICU is somebody who has hemodynamic instability, somebody who's persistently hypotense, maybe they have sepsis, maybe they're intubated on a ventilator. That can't go to a step-down unit, that's an ICU player. Somebody who's on pressors, they go to the ICU. Somebody with severe, profound sepsis goes to the ICU. So that's the only time that we treat pneumonia differently. So if they're going to the ICU because they're septic from their pneumonia and they're on a ventilator or pressors or they're still unstable, they not only go to the ICU, they get a 3-drug regimen. Okay, that's the only changes or difference when we treat pneumonia. Does that make sense? What other things can we do as adjuncts to our pneumonia patient to help them and make them feel better? Yeah, oxygen. Very similar to our asthma, right? We want to give them some oxygen, right? Anybody who's in respiratory distress, we're going to give them a little O2. We're going to help them. What else? Can we try an inhaler? You could. It's probably not going to work because pneumonia is not reversible, right? It's something that we need to treat. Who's at risk for developing pneumonia? Okay, children, elderly, but why? Like who? People who microaspirate all the time. Sorry, I'm thirsty. And it's not alcohol. It's just water. Just so you know. Okay, not yet. It's too early. So people who microaspirate all the time. Who microaspirates? Speaking of which, alcoholics. Okay, who else? Cystic fibrosis patients. Who else? COPD, chronic lung patients. Who else? Okay, very good. Anybody else? Who here, truthfully, has not listened to these lectures yet? It's okay, I won't fault you. You're going to remember this down and dirty stuff instead of, but I do want you to listen to it because it's important. I'm just trying to give you some brief summaries and give you an opportunity to ask some questions about these lectures. Okay, do we want to try, if we have to intubate a pneumonia patient? Just like there's kind of a common theme here. We don't want to intubate asthmatics. We don't want to have to intubate pneumonia. We don't want to have to intubate elderly. We don't want to have to intubate COPD patients. Why? It's hard to get them off the ventilator. They stay in the hospital longer. It's more expensive. They get sicker. All right. There's all kinds of a myriad of problems with it. All right. So we try not to if we can get away with it. Be able on pneumonia to recognize pneumonia on a chest X-ray. Yes, you're supposed to remember how to read a chest X-ray from last semester or sophomore. Major passion, and you can cuss him out if you want under your breath if you don't remember. Okay. Anything else about pneumonia that was striking to anybody who actually listened to the lecture? Any questions, sir, in the back?
Ma'am, for the special population, diabetics, is that type 1, type 2? Does it matter?
It doesn't matter.
Okay.
They're just more prone, and we saw with COVID that patients that are obese and patients who have diabetes and certainly COPD and heart failure patients, they just have a worse course of everything. Okay, and then there's also a subset of patients that are pregnant and they have like this little parasite in there that's just sucking all their antibodies and stuff, so they have a tendency to get sicker too. It's a joke. I'm a mom. Okay. Anyway, But yeah, elderly, diabetic, obese patients just have a worse course. So them having that as a risk factor, just know in your mind that they're at a higher risk for having a worse case of pneumonia than your typical population. And if they're an ICU player, just remember there's a 3-drug regimen. People still get beta-lactams, but now we're looking for special types of anti-pseudomonal beta-lactams. They're getting some anti-MRSA drugs and stuff like that. So your instructor is going to be so kind that it's going to be so easy to identify a pneumonia because they're going to have a fever. They're going to have some respiratory stuff, right? And if you look at their vital signs and they're abnormal or unstable and they need to go to the ICU, you should probably pick the 3-drug regimen out of the options instead of the 2-drug, right? And you need to know basically what kind of drugs are beta-lactam or which are macrolides. And then what's a macrolide alternative? So beta-lactam is penicillins, cephalosporins, things like that. Macrolide or your azithromycin, and another respiratory macrolide is clarithromycin. And then what's an alternative to the macrolides? Doxycycline, very good. Which drugs cover strep and staph? The beta-lactams, very good. Which drugs cover the atypical organisms like Mycoplasma, Legionella? Those are your macrolides or your doxy, okay? That's just the down and dirty. I've recorded these lectures slide by tedious slide just for you, with no jokes, just monotone voice. You're welcome. Okay, let's talk about COPD, all right? How does this differ from asthma? Thank you, it's not reversible. Who gets COPD? Yeah, typically smokers. Worldwide, actually people with TD get COPD. There's a lot of people that have well not a lot, there's a subset of people who've never smoked, but they have an alpha antitrypsin deficiency and they get COPD. There's also an autoimmune type of pulmonary fibrosis, bronchiectasis, cystic fibrosis patients, people like that. And even to a certain degree, asthmatics have remodeling that develop COPD later in life, okay? How do we treat COPD? Are there 4 mainstays of treatment, just like asthma? I know you tell me. What's that? Okay, so let's say a COPD is presenting with exacerbation. This isn't fair to all of you since some of you didn't listen to the lectures yet, but I'm trying to go through it as a down and dirty reminder, kind of like a mid-course review since 4 of our lectures were remote, okay? So I'm just trying to hit some highlights. That doesn't mean you don't have to listen to the presentation if you haven't, okay? I'm just trying to hit some salient points just to kind of plant some seeds for you. COPD, we treat all exacerbations or difficulty breathing with what medication? Or treatment, oxygen. Supplemental oxygen is okay, but wait. You're telling me COPDers, they have high CO2 levels. If I give them oxygen, aren't I going to take away their respiratory drive? During an acute exacerbation, we still do not withhold oxygen. We're going to give them just enough so that they can get by, and we have a goal saturation that's a little different than all other patients. What's our goal saturation range for our COPDers? It's usually 88 to 92%. Okay, I personally just feel better once they kind of get in the 90s, and that's at rest. So that means that if I walk them around, we do what's called a trial of life. They walk around the ER before we let them go. We do this all the time before we let people go home, and they desat to 78. Well, even though at rest they're at 88 to 90, I should probably advocate for this patient to come in, right? Okay. What's the difference between these 2 people right here? These two gentlemen that are just sitting there hanging out. Yeah, which one has chronic emphysema and which one has chronic bronchitis? Also known as? Yeah, these are pink puffers. We still call them that, don't we? They're kind of, let me just ask you a question to ponder. Have you ever met an obese crack hope? Have you ever met anybody that's obese from their crack or methamphetamine abuse? No. Okay. So you've never met an obese emphysematous patient because just like the former, but completely different, they use every single piece of their caloric intake to try to breathe, right? Okay, so they're very thin, pink, they call them the pink puffers, they're pursed lips, and what do their chest x-rays look like? Yeah, you get this hyper-aerated emphysematous lungs, okay? What about these guys, COPDers? okay, the chronic bronchitis people. They call them the blue bloaters, right? What do they look like though? Do they look like that guy? That literally is the model of the guy that I told you about last week that I was walking around with his CO2 in the 80s. That's him. That literally is him. Like, I don't know how they got a cartoon picture of him, but that was him. But no, on a serious note, they do. They walk around like that. For whatever reason, their tissues have just accepted less oxygen at baseline, and so they just kind of look bluish and ashen in color, and they're just a little overweight. Their chest x-rays relatively look normal, unless they have a secondary pneumonia, okay? I'm gonna flip through here. So what are the main treatments of this? I'll put up a treatment slide for you. We give oxygen to everybody. This is just like asthma. Unlike asthma, well, we'll just say like asthma, we're gonna give them albuterol and ipratropium, also known as Duoneb. We're gonna give it to them, and actually the COPDers respond to the ipratropium better than asthmatics, okay? Unlike asthma, who does not require antibiotics, almost never do you give asthmatics antibiotics for their exacerbation because they're being triggered by cold air or a change of weather or whatever. These folks, because they microaspirate all the time and they're always colonized with bacteria, we're going to start them on antibiotics because up to about 80% of the time, their exacerbation is secondary to a bacterial infection. Okay, so we're going to add antibiotics. And what about steroids? I said what you guys told me, and it's true, it's not reversible. Why give them steroids? Yeah, there's still an inflammatory component, so at least we'll calm that down, but we're not going to reverse the mucus plugging and everything like that. We're just going to have to do that with pharmacotherapies and antibiotics. Always tell them to stop smoking. How do we decrease mucus secretion in these folks? I'm sorry? Yeah, you tell them to drink lots of fluids, use a cool mist humidifier. I mean, there's really no mucolytics that actually work, okay? And then lastly, pulmonary rehab. What does that mean? What's pulmonary rehab? They call it a good pulmonary toilet. That's what they call it, pulmonary toilet. What does that mean? I don't want to pick on our RT anymore. I felt really bad after asking so many questions. Anybody else know what a pulmonary toilet is? That would be just like a scheduled regimen of every 4 to 6 hours you're doing a Duoneb, or you're doing your maybe long-term therapies like inhaled corticosteroids, things like that. For acute exacerbations, we'll do IV or systemic steroids for just a few days, but long-term steroids every day is not on the table at all for your chronic COPDers. They can do inhaled corticosteroids, but not systemic steroids. That's bad. Okay, that's bad for your COPDers. All right, any other questions or anything like that about COPD? What reduces mortality in COPD patients? Oxygen, thank you. And there's one other thing they can do to help themselves. Stop smoking. That's the only two things that will reverse their lung condition and mortality. Very good. Okay, so any other questions about exacerbations? I'll do another review prior to exam, but I just wanted to kind of hit on some salient points, okay? Pneumothorax. You guys kind of know about this. I talked about in the slideshow spontaneous pneumothoraces, okay? Who gets spontaneous pneumothoraces? Tall, dark, and handsome people? Oh, just tall and thin, right? Just tall and thin. People with underlying connective tissue disorders, like the Marfans, I heard somebody say, really good. Who else gets pneumothoraces? People with underlying lung disease, like who? Who has underlying lung diseases? COPDers, asthmatics, emphysema patients, right? They're the ones that pop labs. How do we treat pneumothorax? Depends on the size, thank you for saying that. If it's super small, we're going to give them oxygen, observe for 4 hours, and if they're not getting worse and they're breathing okay, we're going to send them home and bring them back 24 hours later for a repeat chest x-ray. Okay, that's if it's small or less than 3 centimeters by measurement. Everything else gets some sort of tube, all right? Who are we sticking fingers and needles in? Only if they have tension, and mark my words. Okay, every exam, somebody tries to do a needle decompression or a finger thoracostomy on a stable, large pneumothorax patient. If you look at their vital signs and they're stable, and their blood pressure is normal, and their heart rate is normal, and their oxygen is normal, do not go needling and finger thoracostomy, no finger thoracostomy for those patients, okay? This is a hospital, you're an ERPA, okay, this isn't pre-hospital, you're on the battlefield and you don't have a chest x-ray capability, all right? This is spontaneous pneumothoraces, and if they're stable, don't stick a needle or finger in there. You may have to do definitive treatment because it's large with a tube, but no emergent heroics happening, okay? No Mark Wahlberg Three Kings sticking a giant needle in there, okay? Only if they're unstable. And what do I mean by unstable? They're hypotense with tachycardia and they appear to be in respiratory distress and they have low saturations, okay? Are you guys with me? It's awfully warm in here today, okay? I actually had to take off my electric vest, okay? Which I scared the CG's team because I mean, it could have been something that's lit up, it kind of looks threatening, okay? But it was just to keep my core warm, okay? All right, who do we put a finger or needle in? Unstable pneumothorax patients, very good. And how do we know they're unstable? Yeah, they're vital signs, right? Vital signs are vital, all right? Classic presentation of a spontaneous pneumothorax is sudden. Anytime a patient presents and they said, I had a sudden onset of something, be scared, like legit be scared. Sudden chest pain, sudden shortness of breath, that's PE, that's pneumothorax. Sudden chest pain radiating to the back, that's aortic dissection. Sudden headache, that's an intracranial bleed, subarachnoid, something like that, okay? Just always know that for test questions. Any other significant questions about pneumothorax? Or pneumothoraces, which is the plural of pneumothorax? No? You guys feel like you got it down? Go ahead. Uh-huh. Oh, absolutely. So you need to be able to look at an ultrasound image. In fact, I have videos on my exam. You need to be able to look at the image or video and discern, is this Sky Ocean Beach, also known as seashore sign, versus is this a barcode sign, or if you see a deep sulcus sign, plus a vignette, if that's a pneumothorax or not. I apologize that we had to do remote teaching. I was ready. I moved here from Colorado, so an eighth of snow, eighth of an inch of snow doesn't intimidate me. I would have been here. But I will go over some of those ultrasound stuff over and over with you, okay? But yes, you need to be able to pick out those images, and those are downloadable. Are you guys able to watch the videos when you download them? Thank you for those of you who watch them. Okay, I get it. I never paid attention when I was in IPAP, like for whatever the instructor was teaching, except for cardio. That was the only one I paid attention to. I was always studying for my next exam, okay? So I understand, but I'll go through it real quick just so you guys all get it, because the ultrasound images can be difficult. When we suspect a pneumothorax, let me go back the other way, ultrasound is actually more sensitive and specific than chest x-ray. And so when we suspect a pneumothorax, we will get the ultrasound probe, and you can actually technically use either of the three probes. But if we're looking at just the lungs, we're going to use a probe called the linear probe. We're going to put a bunch of gel on it, and we're going to stick it in the second intercostal space, mid-clavicular line, with the probe marker towards the patient's head. That's a famous landmark. What else is that an important landmark for? It's one of the two landmarks for needle decompression and attention pneumothorax, okay? So it should be easy to remember. And when the patient is supine or laying down, that's the only area that you have to look to identify a pneumothorax. So we put the probe marker here, and in between two ribs, in between two rib shadows, and so this is what it should look like. So I put the ultrasound probe in between two rib shadows, and what we're looking at is this little pleural line in between. Okay, there's a pleural line there. And normally we see the visceral and parietal pleura sliding against each other. And when we see those two lines sliding against each other, it looks like motion. So again, this is rib. So if I have my probe marker here, I'm having rib, rib. This is the pleural line. This is where the two linings of the visceral and parietal pleura are sliding against each other. Okay, is that better? Okay, you got the two layers sliding against each other. You should see something called marching ants. Okay, that's what they call them, or little comet tails, ring down artifacts, okay? So this is normal. See how you can see kind of some reverberations or little shiny stuff happening? You guys, can you appreciate that? I'm gonna just trying to skip through here. You guys see, kind of looks like it's moving. That's not that one. Go back here. It keeps advancing on its own. You see it sliding here? That little line? Yes or no?
Yes.
Okay, that's normal. We should see that with a normal lung as it's sliding against each other. Versus here, okay, again, it's sliding, sliding, normal, it says normal. Here, now it doesn't want to advance to pneumothorax slide. Here, the patient's breathing, there's movement happening, but the pleural line, there's no sliding, okay? So we see that and we're like, hey, I think there may be a pneumothorax. I don't see any kind of marching ants or sliding. What we'll do, keeping our probe marker in that same spot, all right, is we'll change our ultrasound machine to EMED, which means motion, and we'll draw a little line on it, and I'll teach you how to do that. So we'll draw a little line right over the pleural line on our ultrasound, and then we'll see two different layers. We'll see the visceral and parietal layers look like two distinct layers on the ultrasound. This is normal. This means that there's two layers and it's moving, and the ultrasound is detecting both of them. That's called seashore sign. That's normal. That means there's no pneumothorax. Versus if the air scatters the ultrasound image and it can only hit that first layer of the lining of the lung, it looks like barcode sign. That's synonymous to pneumothorax. Are you guys with me? You guys have had that, some of that before, right? You've had it? You've had. It's okay, you'll get it again, and it looks like we're going to be teaching this right after this block, so you guys will get real proficient at doing the EFAS and be able to pick this up, okay? But don't worry, we're going to go over it over and over. Okay, what do you guys think here? Let's label it. It says sliding lung, right? What about this other part, though? Is the whole thing sliding? Yeah, so you can, so I told you only have to look in one window, second intercostal space, midclavicular line. And the reason why you only have to look in one spot is because if the patient is laying supine, air travels upward and scatters your image, so you'll see that barcode sign right away. But let's say, and you've already answered your question, is there a pneumothorax, yes or no? Okay, so if the answer is yes and you're really curious, you can actually slide down one rib at a time all the way until you can see part of the lung that is still functional or working. And that's what this is. This is showing you where there was clearly pneumothorax with no lung sliding here, and then you slid down long enough to see, okay, here's where the lung is sliding. So almost never is there a 100% collapse of the lung. Sometimes it's just 10, 15, 20%, and the rest of the lung is trying to move. So all you're doing is sliding down rib at a time until you can see some movement. Okay, does that make sense? But that's not, you don't have to do that. If your real question is there a pneumothorax? Yes, no, and then you're done. If you want to get curious, or if you want to say, you know, guru ultrasound, you can say, let me identify my lung point, which is 100% sensitive for pneumothorax. Okay, are y'all with me? It's a quick overview, all right? We're both kind of putting this situation together where we had to do this remote stuff, and I know some of this material you haven't seen yet, so it might be confusing. What do y'all think about this one? We're looking between two rib shadows. Here's a rib shadow, here's a rib shadow. This is this visceral and parietal pleura of the lung. The patient is breathing. Do we see marching ants or ring down comet tails or things that look like they're actually sliding back and forth? No. You are correct. This is bad. That would be a pneumothorax, okay? But maybe my eyes are tricking me. Maybe the patient's splinting or holding their breath. You know, maybe it's not real obvious. So we go to EMED, which means motion. Keep my probe marker, same spot. Don't have to move my probe. And now I'm hitting, I'll hit M again, and it'll give me a display, okay? Which one of these images is normal, showing two distinct layers? A is normal. B, we call a barcode sign. There's not really, even though it looks kind of choppy, it all looks the same, right? We don't see two discernible layers. This is positive for pneumothorax. Okay, you with me? I guess I asked that a lot. It came up on one of my stupid things I always say on the house. Are you with me? Probably in a low voice like that too. Okay, positive, negative. Let's go, let's do one more. All right, let's not. All right. What do you think about this if you saw this CT image? If I said this was normal, yeah, there's some air. Okay, we got that, some soot, right? Some something up in there. There's some air up in there. All right, that's not good. All right, what about this? A lot of soot, right? That would be more than a small pneumothorax, which is what this is. This is moderate to large, okay? It means a tube of some sort has to be in there. And when you finally get to this lecture and you see this, what's wrong with this image? Somebody should be fired, right? Okay, I mean, if you did a CT on somebody with tension pneumothorax, there had to have been some vital sign abnormalities. Okay, this person had to have been unstable and hypotense and tachycardic and hypoxic. And so we've got a mediastinal shift there with a giant pneumothorax here that's shifted completely over and now collapsed the other lung. So this is, what we call an M&M, which is a morbidity mortality. Like somebody's going to be called out on the red carpet for this. All right, treatment, how do we do it? You guys already told me if it's small, it's oxygen, high flow, like 15, 20 liters per minute. We watch them for 4 hours. If we repeat the chest x-ray, if it still looks okay, patient's stable, we can send them home and bring them back in exactly 24 hours, repeat chest x-ray. If they're still looking good, then they'll absorb over time, all right? If it's larger than that, they need some sort of tube, and whether you choose a pigtail catheter, which is what we use a lot now for, more than small pneumothoraces, so something that's at least decent sized, greater than 3 centimeters, we'll use a small pigtail catheter. And then if it's super huge or traumatic or recurrent pneumothorax, we'll use a large chest tube, okay? Just try to summarize that for you. All right, am I confusing anybody by hitting some salient points? All right, I'm actually giving you almost like a review for your exam, like that's what I'm doing right now. Okay, so how do I know when I'm, if you've ever seen a pigtail catheter, it's very similar. You can actually put it in the second or third intercostal space, midclavicular line, very similar to our needle D. We actually stick this little trocar, and I have a picture of it on the slideshow. There's a little video of people putting a regular sized chest tube as well if you go to that site. But if you're doing a pigtail catheter, it's like a cell dinger technique. You're sticking a needle in the chest, you're sticking a guide wire through the needle, you pull the needle out, then you're threading a really small tube. They call it a pigtail because when you open it up out of the package, it has a little introducer in it. It's all curled up like a pigtail. You unwind it and thread it over that wire that you just stuck in the chest, and then push it in all the way, pull the wire out, then attach it to a 3-way stopcock, and you take a 60cc syringe and you just start taking all that air out of the chest. Okay, I turn the stopcock, pull out the air, turn the stopcock, release the air, and just go back and forth till I get all the air out of the chest to help it reinflate. Now, it's still not going to be like Mark Wahlberg, 3 Kings, it's like no psh, and just reinflate like a balloon, okay? But it does help get all that air out. How do you know that you've gotten all the air out? So either the patient will start to cough, you'll induce a cough reflex, or you'll start actually aspirating pink frothy fluid into the syringe, and that's when you know you're done. You turn off the stopcock, detach the syringe, make sure the stopcock is turned the correct way, because if you walk away and it's not, then guess what, air is going in there, and next thing you know, like, your patient has tension pneumothorax that you already put a chest tube in, and you're like, oh man, that's not good, right? That's a bad day. So anyway, those are the differences. Or if it's a large pneumothorax, you would put a giant chest tube in, which used to be the standard. And this is a pigtail catheter. Pigtail. This is where we stick the needle in. The guide wire, which is here, and then thread this catheter over it. It's actually pretty cool, and they're pretty new. And that's what we use at the MC now quite frequently. And there is a little video that you can watch here if you go to this website that actually will show you the steps to doing a chest tube. We also practice these in block 4, and then you get to do them for real during our ATM lab. You get to do a legit live chest tube, which is pretty cool. Okay? Any questions about pneumothorax? This is just primary and secondary spontaneous pneumothoraces. It's not till block 4 or trauma block that we start addressing traumatic pneumothorax, because that's a totally different ballgame. Okay? Any questions? All right, you guys ready for like a 5-minute break or so, and then we'll come back and we're gonna just do an ECG overview. This is me reminding you what you already learned last semester about EKG so that you can pick out acute coronary syndromes, all right? It's just a down and dirty. You're not tested on this slideshow per se, but you need to know how to interpret an ECG, okay? So is 5 minutes enough? Okay, let's do that.